What a wonderful day. This is the end of the beginning. And it is so exciting to be here with you. On behalf of the Secretary's Advisory Committee, thanks for being here. Thank you for your participation. And I'd like to start by thanking the members of my committee, one of whom will succeed me on this podium, but I'd like the others to stand up, and I want to recognize them if I can see them from here. Adewale Troutman. There's somebody there named Moya, I think. Eva Moya is there. And there is Lisa Iazoni. And as far as I'm concerned, they were a key part of this dream team. If I can have the first slide, please. Maybe the second slide. You know, it's really exciting to think about the changes. This started a long time ago in 2007 with the National Opinion Research Center, that put up an expert panel in 2007 to try and they suggested a few things based on looking at 2010 objectives, and that was to organize the objectives around some cross-cutting risk factor and determinants and to use an inductive process. And then the recommendation that some of us got to understand, couldn't understand why they made it because it took so much time, and that was to convene a Federal Advisory Committee. And the Federal Advisory Committee, I must say that people put in so many hours of volunteer work. I'm just awed by the level of participation and the wisdom of the people who are on this group. And what were some of the things that we recommended at first? Well, one of the first was we said, societal determinants have to underpin the initiative. Those are overall the major determinants of differences in health and health overall in populations and of health disparities. We said the objectives could no longer be contained in books. There were a couple of orthopedists telling me that they'd seen some people who'd been trying to lift all the 2010 books that and they needed therapy. So we thought it was time to change, and that it was time really to house these in a web-based relational database. And then the question came up, well, should we just limit the number of objectives? And when we looked at the opportunities and said, well, they can tailor this now to the needs of individuals and to organizations, we said, no, there really shouldn't be any arbitrary limit on the number of objectives. Well, this has been a very inclusive process. In 2008, we had 5 regional meetings. We had 2 in this area, 3 other places, had over 300 comments at those meetings. In 2009, we had 3 more regional meetings with almost another couple hundred comments. And then, of course, most comments were submitted online. In 2008, we had over 200 comments on the framework, on the organizational structure. And then in 2009, we had over 8,000 comments on these objectives submitted. Next, please. So what's new in terms of our recommendations for Healthy People 2020? I can't say this enough, and I'll only say it once a slide, to recognize the importance of the underlying determinants of health, but also to focus on the evidence base, to really utilize evidence-based interventions to help implement and utilize the initiative. If we don't know what we're doing because we don't have good evidence, we better have a good reason for doing something. To offer the web-based system because this enables the activity to be very particularized to the needs of individuals, but also to be flexible. As we get more knowledge, we can change these over a period of the decade. And also provides topics that better meet the needs of healthy people users. Dr. Koh, who's been a wonderful leader in this enterprise, already talked about some of the new areas that weren't covered at all. Can you imagine thinking about healthy people in 2020 without thinking about the issue of preparedness, unfortunately, or whatever? Next, please. So the overview of the work, we were the first fully public advisory committee to participate in the development of Healthy People. We were governed by those regulations. Everything we did was in public view. We first convened in January 2008 and met 17 times. And I know people are concerned about the cost effectiveness of government. Well, let me tell you, since all our hours are volunteered, it was a good value. There were there were multiple subcommittees and ad hoc groups, a total of 13, organized around topic areas, and those allowed very in-depth discussion. We had experts, and I'm sure some of them are in this room, too numerous to cite individually, who were very, very helpful. We had subcommittees that had subcommittees, and they met about 50 times, and each one gave a productive outcome. Next, please. So here, without going in detail, for which I'm sure you'll thank me, are the products of the committee's work, and those are all now online, and I commend them to your attention because they all took a lot of work. And we started off in March of in October 2008 with our first recommendations, and our last recommendations to date occurred only a few months ago. That was on the most important part of this, the part that we're all concerned about, and that is all committed to, and that is implementation. Because one of the problems in the past has been that there have been a lot of objectives, and people have, said, these are great, let's think about them, but there hasn't been the accountability framework, there hasn't been the level of partnership, and there hasn't been, to the degree there needs to be, the intersectoral collaboration. I always say in public health, there's very little in public health that we can do alone, and there's almost nothing we can't do with the right partners. And this requires, as Dr. Koh said, all the right partners. Next slide, please. So here are some key recommendations. One, to base objectives on what the best evidence shows is achievable. Use the clinical guide, use the community guide, use Cochrane collaboration, use other meta-analysis, but make sure we look hard at the evidence. Make the objective setting process transparent. We always have problems trying to set objectives. How do we set them? But at least if people know how we've gone about it, they'll know how to change it, what changes can be made, or as we get new knowledge. For all objectives, implement them where they have clear evidence of effectiveness whenever available. Set some priorities. Where areas we know where we have great preventable burdens based on existing evidence, use that. And if in fact that level of evidence isn't available, ask whether that's the right thing to be intervening on, or whether one should not in fact look at other interventions that have clear evidence of effectiveness when you have limited resources. And of course everybody has very limited resources. Then every objective should be developed through the use of an analytic model or logic model. It means just very simply, how many of you here use logic models? Okay, well that's about 3/4, and I'm sure the rest now are wondering, now why am I not using those? But basically it says, how do you get from point A to point Z? What is the pathways along the way? Where do the interventions work? What is the effect size you'd expect? So everybody's very clear not only what you're doing, but why you're doing it. Next. And then ensure an accountability infrastructure is in place at all levels of government, including the federal government. We hope, as the advisory committee, that all parts of HHS, but other agencies as well, will incorporate this framework and these objectives and the interventions as part of their accountability framework for themselves, and for their grantees, for their partners. It's essential to leverage the resources through partners and networks. I know everybody says partnership's important. Well, collaboration to some is an unnatural act. And if you don't collaborate, you can't improve the health of our nation. You can't reduce the level of disparities that we have that are really yawning. We have to improve the data system to ensure monitoring objectives. In some cases, that's a problem. And we have to make participation at the Healthy People Consortium significant and meaningful at the state level, at the local level. In my own department, we are in fact developing a whole set of outcomes based on the Healthy People framework, and we're doing it as part of a broad partnership. Create a clear, empowered role for the Healthy People state coordinators. There is a coordinator in every state. Make sure you know your coordinator, and make sure you help your coordinator. Identify and select specific measures to track processes and impact. So we have to get measures of how the population is changing at large with respect to the key measures, but also the subpopulation. Just to give you one example, in our own county, in Los Angeles County, the difference in longevity between an African-American male and an Asian Pacific Islander female, the average longevity is 18 years different. That's unacceptable. Healthy People can help us on the path to narrow those by moving everybody in the right direction. And then identify and disseminate planning models that have been adapted to focus on societal determinants. The physical, the economic, and the social determinants are absolutely critical. We don't have as much evidence as we'd like in every case, but there's plenty of evidence to get started. Next, please. So here are just a few of the challenges. Getting collaboration is not easy. Very important to involve business, very important to involve the nonprofit sectors, but critically important to involve all those different sectors outside the health sectors whose decisions make differences in health. And Dr. Benjamin will be chairing that National Council, Prevention Council, and with all those different agencies involved from the Cabinet and other White House appointees, it has great potential to make a huge difference. And we look forward to seeing the significant output of that. In some cases, we're not going to have the evidence we'd like right away. For example, we don't in many cases know the most effective ways of reducing health disparities in the short run. We do over the long run. We think we do. We have some very good ideas. We have some examples, but we don't in the very short run. And then substantial efforts are sometimes needed to monitor progress and to implement new information. In some cases, there are objectives, and you only get that information once a decade or once every 5 years. And you need to get that information more quickly and at a more local level to see, in fact, how the needle's being moved. And finally, there are times when there are going to be long delays between some interventions and the objectives, and we have to have patience. But for others, impatience may be the best virtue. Next. So thank you very much on behalf of the committee. We are very excited to see this come to the end of the beginning. Now the hard work starts. We want to be helpful. We look forward to working with you. Thank you very much.